Streaming live.
Good evening, all. My name is Simran Chaudhary, and I welcome you all on behalf of Voice of Healthcare and Bharat Serums and Vaccines to this virtual edition of National Prostate Cancer Forum and Awards. National Forum and Awards Forum brought to you by Bharat Serum and Vaccine. And we are truly delighted to have each of you join us online this evening as we bring together some of the most distinguished voices in oncology and urology for a focused conversation on addressing challenge in the present era of
Hello.
prostate cancer.
Yes.
As we know that prostate cancer continues to be one of the leading health
Madam, I'm
concerns
actually in
among
a
men,
conference. I'll just call you back.
navigating its clinical
I'll call you back.
complexities. From early detection to
I'll call you back
advanced
soon.
treatment,
Huh? I'll call you back soon.
requires constant collaboration, innovation, and cross disciplinary dialogue. In this forum, we aim to explore current challenges and emerging strategies in prostate cancer care, particularly in context of evolving landscape of robotic surgery, access to quality treatment, and patient-centric care. And we are and we are honored to be joined today by a distinguished panel of experts. Dr. M. Anandan, Professor and Head Department of Urology and Consultant Urologist at Kovai Medical Center and Hospitals, Coimbatore. Welcome to our show, sir. Thank you so much for joining, sir. Dr. Himesh Gandhi, Chief Robotic Surgeon and Consultant Uro-oncologist, Ruby Hall Clinic, Pune. Welcome, Dr. Himesh.
Thank you for the invite.
Thank, thank you so much for joining, sir. Dr. Sudhir Chadha, Chairman and Senior Consultant Urologist, Department of Urology and Kidney Transplant Surgery, and an Honorable Member of Board of Management, Sir Gangaram Hospital, New Delhi. Welcome, Dr. Sudhir.
Yeah, thank you, Simran, for the invite.
Thank you so much for joining, sir. Dr. Mangesh Kamath, Additional Director, Medical Oncology at Fortis Hospital, Bangalore. Welcome, Dr. Mangesh.
Good evening. Thank you so much.
Thank you so much for joining, sir. And a heartfelt thank you to each of our speakers taking time to be with us virtually. And we look forward to this engaging, insightful session that highlights the both challenges and actionable opportunities in the prostate cancer ecosystem. And now I would like to hand over this conversation to Dr. Kamath, who will be moderating this session. Over to you, sir.
Thank you so much, Simran, and good evening, gentlemen. Warm welcome to Dr. Anandan, Dr. Himesh, and Dr. Sudhir Chadha. So, as you would all understand, that we are trying to understand what would be the latest advances in the prostate cancer management. And this is not just about the national management, but is the international consensus that we are talking about. And we have eminent panelists with me. Me being a medical oncologist, most of my role comes in when you are the urologist, evaluate the patients. They even treat the patients when they are non-metastatic in a localized or locally advanced setting, and then when all the surgical or the radiation techniques have been exhausted, usually the medical oncologist comes into play. Now, if you really look at it, there are a lot of things that we need to remember about prostate cancer because most of the time, if there were 100 prostate cancer patients, you would find almost 90 of them would be seen by the urologist first. And 10 of them would somehow find a way to somebody who's not a urologist, maybe a general surgeon or maybe a medical oncologist or a radiation oncologist in fact. So, as we would like to delve into the basics of prostate cancer, let us start with something that we most commonly want to know in our clinical practice. So, let me start with Dr. Anandan. Dr. Anandan, how commonly do you see prostate cancer in your practice? For the information of the public here.
Yeah, the common in the sense I cannot give an exact percentage from the total clientele of my practice, but of late we are seeing increased patients being detected with prostate cancer, more localized prostate cancer, and if you ask about the staging when they present to us, previously more than 95% of them will present with the later stages, most likely in metastatic stages. Now we are seeing more of them in the localized stage where curative intent treatment is possible. Um, so, as such, the pickup rate of prostate cancer is also increasing. Previously, we used to see the other cancers more commonly, but now the pickup rate of yearly and also late prostate cancer is more, especially with the widespread use of PSA among the general public.
The second question I would like to ask you is, how many patients do you get who have been diagnosed to have high PSA levels on master health checkups that they routinely undergo, and then they come to you? And how do you usually approach these patients?
Uh, for the past 8 to 9 years, we have started to include PSA among the patients who are undergoing master health checkup, and almost 95% of the localized prostate cancer we are picking up by the master health checkup by evaluating for increased PSA. So yes, definitely the pickup rate has gone up with master health checkup. And if the PSA is more than 4 with a normal DRE, the percentage of patients who finally turn out to be patients of CA prostate is close to around 25% in our practice in this part. And moreover, even prostates with hard prostate with locally advanced cancers are also being picked up by mass health checkup, because we all know the PSA is the only diagnostic modality. The patient presenting with symptoms of CA prostate is quite in the advanced stages. So in many patients, we are also picking up advanced stage prostate cancer by doing PSA in mass health checkup also, and also DRE.
So the one thing that the audience needs to remember when we're talking about prostate cancer, and as Dr. Anandan said, almost 25% of those patients who have an elevated PSA levels on master health checkup, and also maybe their ultrasound scans which they do during the master health checkup also shows that there is some prostate enlargement. So these patients are very easily diagnosable if you undergo PSA levels. And also your ultrasound abdomen pelvis examination. So, at what age, Dr. Anandan, do you recommend PSA levels to be tested routinely by men in our country?
In our country, I usually ask them to test PSA after 50 years of age.
Okay. Okay. So please remember, more than 50 years of age, you will try to get a PSA testing done and also an ultrasound abdomen. If you do have any urinary symptoms, even before the age of 50, please do get evaluated by a urologist. There are simple examination methods. In fact, bedside examination, you can definitely diagnose a lot of cases of prostate cancer. As Dr. Anandan and other urologists would say, they would do a digital rectal examination to try and understand if the prostate is abnormal, and then probably do the further evaluation. So my next question is to Dr. Himesh. Welcome, Dr. Himesh. So we know that prostate cancer is one of the leading cancers across the world. Now, how common do you think prostate cancer in our country, and do you think the awareness about prostate cancer is adequate enough in our country?
Like Dr. Anandan clearly mentioned, the rising trend of prostate cancer in India. Now, if you see the statistics, now last reliable statistics is from the GlobeCan data that was in 2022, where they estimated approximately 38 to 30 now 9,000 new cases every year. And if you see the male burden of prostate cancers among all cancers in male, it forms around 5 to 6%. So this data is continuously rising, and as per the proposed estimation, by 2026 we would be seeing somewhere around 50,000 new cases every year for male diagnosed with a prostate cancer. As such, the trend of prostate cancer, what we see in India, is quite different, because when we take into consideration the average stage of the disease, we see predominantly patients in stage 2 and 3, unless he is a high profile executive who goes a regular health checkup and then he is diagnosed at a very early stage. But in a routine practice, the patient who presents with some lower urinary tract symptoms on evaluation subsequently, they are found to have at least stage 2, stage 3 plus disease. What I would say predominantly is 3A, 3B. So, in Indian scenario, we cannot take prostate cancer lightly. Even what all said and done, that it is a very slowly progressing disease. In our practice, we see the youngest patient diagnosed with the prostate cancer was a 35-year age. So it is family history, then predisposition to our climatic conditions, hot and humid climate, features of chronic prostatitis, and similarly, if the patient is a de novo patient after 50 years, like Dr. Anandan told us, these are the few indicators where we should be very suspicious of diagnosing an early prostate cancer rather than missing the bus.
Okay, that's great. So please remember that it is not an uncommon cancer, and there is a saying amongst urologists and oncologists alike about this is that yes, there are more chances, high chances that a patient may die with prostate cancer than due to prostate cancer, but that does not mean that we don't diagnose and treat prostate cancer. So it's very important for us to make sure we get this. Let me come to Dr. Sudhir. So Dr. Sudhir, you have considerable experience in treating prostate cancer patients, but you do get a lot of patients who come to you initially with some urinary tract symptoms. Maybe they have a urinary tract infection, or they have a difficulty in passing urine. They feel that they are incompletely voiding urine. So when you get a patient like that, how do you evaluate this patient, and what are the investigations that help you to understand that this patient could be having a prostate cancer, and how do you further evaluate these prostate cancer patients? So these are three-part question. The reason is the audience should know how exactly urologists and oncologists would like to evaluate a patient, and so I would like your inputs on this, please.
For cancer of the prostate patient, it is very essential that the urologist is kept in the loop. For once, I always recommend our hospital authorities to get the PSA in the normal routine checkup, whichever is done above the age of 50 years. Once a patient comes to me with the suspicious of lower urinary tract symptoms, or with elevated PSA, or with backache, first and foremost thing to do is the digital rectal examination of the prostate, which I emphasize on all my residents, that no urological examination is complete without the digital rectal examination of the prostate. Once I have done the digital rectal examination of the prostate, I have got some idea of the health of the prostate. Next step is, of course, to get the ultrasound, KUB with the residual urine and the transrectal ultrasound for the prostate, and PSA examination free and total done. And of course, urine examination is the first and foremost examination to be done in all the urological patients. These three things: physical examination of the patient, ultrasound, specifically for the trust for the prostate, and PSA and urine examination thing. These in conjunction give us the first line of the diagnosis for the CA prostate if there is any. Once we have got suspicion or strong suspicion with these investigations, next step is to have the prostate biopsy done. In our practice, once the biopsy is positive, next thing we go in is for PSMA PET scan. And this is the protocol which we follow in our practice, and this is what we have formalized in our department also. Physical examination, ultrasound, urine examination, and PSA levels. After that, if suspicion is there or strong suspicion is there, we get trust-guided biopsy and followed by PSMA PET scan. This is the way we evaluate our patients.
So just to summarize whatever Dr. Sudhir Chadha said, please remember a robust clinical examination is still not out of vogue. We have to spend time in our clinic and make sure that we do a good digital rectal examination. And then, of course, we do a scan after doing a PSA levels, and after that, a biopsy. A biopsy is very important because you need to know what kind of prostate cancer is it. Most of the time, it is adenocarcinoma, but in that, you need to know your stage, the grading, The Gleason grade has to be very, very clearly mentioned, and based on this, you can even help to understand how aggressive the prostate cancer will be. In many cases, prostate cancer is very, very slowly progressing, like Dr. Himesh said, and many a times the patient doesn't even come to the clinic and is accidentally found to have prostate cancer while evaluating for something else. But there are going to be really aggressive ones, the cancer ones, which are going to be very difficult to handle sometimes, and despite all efforts, they can cause a lot of trouble to the patient and give us a lot of headaches during our practice. So let's go to the round two of our discussion. We'll discuss about what are the diagnostic markers and the surgical management. Now, as we have highlighted in the first part of the discussion that we are doing PSA, we are doing a biopsy, and then we are doing a scan. The PSA and ultrasound scan helps us to point that this could be prostate cancer. Then we are doing a biopsy because we need to know whether it's prostate cancer or a benign prostatic hypertrophy. Sometimes it can be just seen as that. And third is the most important, to do the staging. You want to know whether the PSMA scan is telling us that the disease is localized to the prostate or just extending nearby the prostate and involving or touching the nearby organs. And last but not the least, whether it has spread to other organs. So I'll bring in Dr. Anandan to talk about this. Dr. Anandan, after you have got to know that this patient has prostate cancer, you got the grading. Now you do a PSMA scan. So please guide us through how do you interpret the PSMA scan and give us a rough blueprint as to which direction of treatment the patient goes to depending on the PSMA scan.
Yeah. First, once we diagnose the disease by the biopsy, next we need to know whether the disease can be completely cured or whether it can be just be treated, because there are some stages where we cannot completely cure the disease in the patient, and we have to just control it. To know this, we have to know whether it is only within the prostate or nearby, or it has spread beyond to the other organs like bone and the other extensive lymph nodes. So the PSMA PET is very much helpful in diagnosing whether the cancer has spread beyond the prostate or the local extent. So in PSMA PET, we can see the lighting up of the prostate gland, and if it has spread beyond, especially most likely in the bones. The prostate cancer mostly spread to the bones. If the bones also light up with the PSA scan, then it means it is spread beyond the prostate. So there is no possibility of a cure, and we have to just treat the disease and keep it under control. If it is not spreading beyond the prostate, then we have to do an MRI to stage it locally to see whether it is present only within the prostate or it is involving the nearby structures. If it is localized only to the prostate, then we'll advise him surgery for the removal of the prostate gland. If it has spread a little bit beyond, then we will advise him radiotherapy. So first we will do a PET scan to know whether it has spread beyond the prostate and the nearby areas, and if it is not, it has not spread beyond the nearby areas, especially to the bone and other things, we will do an MRI to know whether we have to suggest surgery or a radiotherapy.
Okay. So let me come to Dr. Himesh now. So Dr. Himesh, you definitely work in one of the big centers in Pune, but do you always require PSMA PET scan for your staging evaluation to tell the stage, or can you do something else in maybe tier 2 cities or tier 3 cities?
Yeah, so I'll just differ from the normal protocol. What the I think the rest of the India is following. So what we normally do is, whenever we have a elevated PSA, we do a test called PHI, Prostate Health Index. So basically, we don't directly embark for the biopsy. Then subsequently, once the PHI value comes more than 55, we then have a high, strong suspicion that the possibility of cancer is 40% and a significant cancer is more than 20%. Then we post the patient for multiparametric MRI prostate, which gives us an adequate idea about what is the regional status of the patient for the local staging part, and also as a guide marker for the biopsy. And once the biopsy is positive, then if it turns out to be a low risk candidate, then we don't necessarily require a PSMA PET scan. We can plan for a direct definitive treatment option, and if it forms a unfavorable intermediate risk or a high risk patient, then definitely we will like to stage it with an in with a PSMA PET scan, and then subsequently plan the definitive treatment option.
So, Dr. Himesh, if I can ask you to describe in simple terms, how do you do the PHI?
So PHI basically it's a blood test, and it takes into consideration the total PSA value, free PSA value, and a pro to PSA value. So there is a formula where you have a total PSA into square root of pro to PSA, and the you have a free PSA and into the square root of pro to PSA and the total PSA, and you find out a value which gives you a reliable indication regarding the possibility of finding a significant cancer when the PSA values are more than 4.
So, if the PSA on a routine testing is more than 4, and
Yeah.
for some reason, based on the calculation, the PHI comes to less than 20, would you not do the biopsy?
So when you take the PHI value, what we get in the report is a total PSA, a free to total PSA ratio, and finally the PHI report. So when we normally tend to take all the considerations, and then we have to exclude all the other factors which might cause elevated PSA, like retention, like calculus, like infection. If all these factors are nullified, if the free to total ratio again shows less than 15, and still the PHI is showing less than 21, this patient ideally have some form of infection. We can have a wait and watch approach, give a 3 months of antibiotics, repeat a PSA, because anyway it's just maybe less than 10, and we can just follow up these patients with just simple PHI values.
Okay. So now let me assume that this patient who has come to you has been diagnosed with prostate cancer by a biopsy. Now,
Correct.
and based on your PSMA, it was localized, and then you then you made the patient undergo multi-parametric MRI study, and you found that it is a localized. Probably you can say it has not gone to any nearby structure also. How would your approach be for this patient?
So first thing, what is the risk category of this patient? Second thing, what is the age of this patient? What is the life expectancy we are expecting? What is the performance status? All this, if it's favorable, he is a young patient, a sexually active patient, then a definitive treatment option falls into the category. Now, if it's a localized disease, we have multiple options as long as it is in the favorable intermediate risk zone, starting from the low risk to the favorable intermediate risk, where we can use an option of a focal therapy. We can plan maybe something we often recommend to a young sexually active patients like cyber knife. We can then give an option of a robotic surgery. So there is a basket of treatment options when we are considering a low risk, a favorable risk, intermediate risk prostate cancer patient. But as the criteria changes, like the patient is an unfavorable intermediate or a high risk patient, then we have to be more aggressive, and definitely we will be more depending on the life expectancy and all, we will be giving a more radical approach to those patients. So it can be either in form of a robotic radical surgery, or it can be in terms of a RT.
Okay, so just for the audience to just know what Dr. Himesh was talking about the risk stratification. Why do you need risk stratification is to guide your type of therapy for the localized prostate cancer patients. So there are multiple risk groups that we talk about. We'll talk about very low, intermediate, high, and very high. Now I don't want to complicate much of this, but these risk groups are basically determined based on the PSA levels. For example, a very low PSA level in a very low risk group, it will be PSA of less than 10, whereas in a very high, it will be more than 40. And second is the stage or the localization of the tumor. If it is very low, it means it is T1 or a very small lesion. And if it is very high, it means it has gone and touched the nearby organs. And then we are also looking at Gleason's grade, whether the Gleason's grade is group 1 or whether it is a group 4 or 5. So these are some of the factors that help us to understand what kind of risk group are we talking about. But then there is one more thing that we always look at is the life expectancy of the patient. Life expectancy is very important because if you have a patient who has very few years to live, for example, you diagnose a patient in 75 years age with prostate cancer, and you are assuming that the prostate cancers that patient's survival is not going to be more than 5 years. So your protocol will change. You may not opt for surgery sometime. If you may sometimes just give radiation, you may not even discuss about surgery. But if there is a patient who is expected to live for more than 5 years, or if there is a patient who is expected to live for more than 10 years, and the patient is symptomatic, then you can discuss the options of doing a surgery or a radiation for these patients. Now, Dr. Himesh, I will just ask the same question to you. How do you determine between an open or a laparoscopic or a robotic surgery? Because now almost every hospital has a robo. So we need to know why we are, why, what is the hype behind this robo? Why not just do a laparoscopic? Even that is minimally invasive according to everybody. So can you just point it out in a few sentences?
I would say this is an excellent question because there has been a gross misconception regarding the overuse of robot. But the thing is that now when we talk about a prostate cancer, so the situation of the organ itself is in a complex position. It is in the deep down in the pelvis. Now, when we were talking about open surgery era, now the issue with the open surgery area was that the nerve preservation was one of the big factors where almost 50% destruction of the nerves was happening. Second thing, the bleeding was one of the criteria where we have seen up to 1 liter of blood loss happening. And third thing, if you see the long-term data, the recovery of the urinary control, that was one of the factors determining the post-operative outcomes. So subsequently, there was a switch because of all these problems to a laparoscopic era where the vision was great, the reach was great, but then again the dexterity of the instrument was a limitation, and people were cutting corners in taking a proper stitch between the bladder and the urethra at the end stage of the disease. So subsequently, we felt the need that there has to be a refinement in the technique which gives us excellent precision, a magnified vision, minimal blood loss, excellent nerve sparing, and almost a good acceptable continence rate at the end of 3 months. So these all criteria were fulfilled with the help of robotic technology, and that is why it because of the ease of the technology, there was a rampant shift from a laparoscopic approach to the robotic approach, and obviously the blood loss, which was quite significant in open and laparoscopic era, has reduced tremendously with the help of robotic surgery. So this was few of the key indicators which necessitate a shift from a laparoscopic open surgery era to a robotic surgery era.
Great. So, since we are on the topic of robotic, I'll just have Dr. Anandan also putting some points. In your practice, which would be the right patient to select for a robotic surgery?
See, as far as prostate cancer and radical prostatectomy is concerned, as mentioned by Dr. Himesh, so robotic surgery definitely holds an edge over the even the open surgery. So any patient who is affordable for minimal invasive surgery, the cost wise, is a candidate for robotic surgery. Nothing to take away from the open surgery. Open surgery is almost equally good in the continence rate and the potency rate in the surgical hands who have a good experience. But the ease of surgery and the better preservation of the nerves and the better continence in all patients is one of the use of using the robotic surgery. And if you ask who is a candidate for robotic surgery, any patient with CF prostate is a candidate for robotic surgery. But one drawback is the patient has to be placed in a steep head-down position. And if the patient has got some issues, then where we cannot put him in a steep head-down position during surgery, this we can consider it as a contraindication for robotic surgery. So even in such cases, there are some various approaches where we go just in the extraperitoneal space, the radius space, and do the robotic prostatectomy. That can be done in a lesser head-on position. But given a choice, to me, I would prefer robotic surgery to open or laparoscopic surgery for radical prostatectomy.
Is there any patient who you would not recommend a robotic surgery, just to educate our audience?
Yeah, only patients are who have lung issues, on whom we cannot put in a steep head down position, where steep head down position is necessary for radical prostatectomy robotically. So in such patients, we have to go for open surgery.
All right. So let me go to Dr. Sudhir Chadha also for his comments on this same question. So which of the patients that you prefer to do robotic, and is it okay not to do robotic in your practice for some of the patients? I just wanted you to summarize this for us again.
See, in the era of robotics, in almost every hospital, the era of open surgery is almost over. In fact, when I went to Cleveland Clinic for my training, they were doing open surgeries. But when I came here, open surgery was absolutely not done. And my boss was always used to discourage about regarding the blood loss and the high risk and the poor result. All the I don't cancer, localized prostate cancers.
Okay, I think we lost you there for a few seconds, but I think what
I
you're
will
saying.
I will repeat again. In the
Yeah,
era
yeah.
of robotics, which are very commonly now appearing in almost all the major hospitals in the country, the era of open surgery for the prostate is almost over. And the
Okay, okay.
only yes, that's what I strongly feel.
Okay. So now all three of you are surgeons. So is there any patient, just again summarize it in a few points, whom you would not want to do a surgery and just refer to your radiation oncology colleagues for treatment?
Oh
Dr.
yes, a
Anandan,
lot of
start
patients
with
are there who are scared of surgery. A lot
okay.
of patients are, very high risk for the surgeries or life expectancy, as our co-panelists have told you, less than 10 years. Definitely, I am not going for a major surgery. A lot of comorbidities, diabetics, there are high risk cardiac disease is there, COPD is there. They are not fit candidates for this major surgery. They will definitely going for radiation. See, radiation and surgery, they are competing for the localized disease. Radiation and surgery, they are competing for the local, and almost every center is now telling us the results are almost comparable.
Okay.
So
Okay.
I would like to add in this. Now we are going to in next 5 to 10 years. We will see like what has happened in US. Extensive use of focal ablation for the treatment of prostate cancer, which I would say that in India is in evolving phase where focal therapy also will come a big player, because if the patient is able to have maybe a cancer free survival for at least 10 to 15 years after a single or maybe one additional focal treatment, he is going to select this option rather than going for any radical approach, either a robotic surgery or a definitive radiation therapy. So it's very much in the near future that focal HIFU or that Sonablate or focal one adapt, they are going to be one of the key players in the management of early prostate cancer.
Dr.
Lot of
Anandan,
people are already
let me
approaching us.
yeah. Dr.
I was
Anandan,
saying that uh,
please go ahead, Dr.
lot of
Sudhir.
companies are again approaching us for installing this HIFU and solar blade things, and I am sure if we don't hello.
Yeah,
Yeah,
we
yeah.
can hear
Please,
you.
sir. Please. We are
If we don't
listening.
take these things up, these things will go to interventional radiologists. I am sure that we should, as a urologist, we should be active and take these things within our domain.
So I was going to ask this controversial question to Dr. Anandan. So Dr. Anandan, do you, Dr. Sudhir stole my words basically, a question. So Dr. Anandan, I just wanted to tell you, Dr. Sudhir himself also told that the results with radiation, at least the latest advanced radiation techniques and now there is a lot of hype about proton. Proton is being offered left and right to especially those patients who can afford it. So in the long term, let us be keep your urology hat aside, but you also work in a center which has radiation therapy. So over the long term, what do you think will probably lead the fray when it comes to treatment? Is it radiation therapy? Is it surgical technique? Or is it intervention radiology based ablation techniques in the future? I am talking only about localized prostate cancer. Let's not bring in other stages.
Yeah, it's a good question. Right now, the radical prostatectomy holds an edge over the radiotherapy. Still, with all the cybernef and other modalities, still the radiation-induced proctitis and radiation-induced cystitis is still one of the common disturbances felt by the patient after radiation. And the we have seen a few cases of carcinoma bladder after irradiation of the prostate or carcinoma prostate, second malignancy as such, or is a definite possibility after radiation to the prostate. That is one of the drawback, if at all, we can consider after radiotherapy. With the better surgical modalities like robotic surgery, the continence rate has definitely improved, and also the erectile function has improved after surgery. So, and as mentioned by Dr. Himesh regarding the HIFU and other modalities, these are for specific indications where there is cancer in particularly one of the lobes of the prostate. It is still a controversial, like whether it is a diffuse disease of the prostate or it is located a single lobe, where we have to ablate a single lobe or complete ablation. So still more research has to be done to select the appropriate patients for HIFU. Suppose if we leave a focus of high grade disease like a Gleason grade of 4 and ablate a Gleason 3 grade disease and the patient presents with the recurrence, it will be a problem for the patient. And doing a surgery in a previously patient undergoing HIFU, undergoing radiation or radical prostatectomy is going to increase the complication rate. So I feel radical prostatectomy would be the first modality of choice, followed by radiotherapy, and HIFU as such would be the third option.
So, Dr. Himesh, let me ask you a very controversial question. Dr. Himesh, you there?
Yes, sir.
So you have a very close friend in your hospital who's an intervention radiologist. He's your batchmate and maybe your
Yes.
Friday night party friend.
Yes.
And you have a radiation oncologist who's okay, not a great friend, but a good colleague.
Yeah.
So
Correct.
now you have a patient who says, Dr. Himesh, I don't want you to operate me. Give me the choice between an ablation of radiation. Which one would you give?
That's a tricky one. So finally, what I would say that what is the
Friendship
patient's expectation? What is the
Friendship
patient's
is-
expectation? Yeah. So one is my Friday night partner, and the other guy is not that great partner because he eats up my lot of work. So obviously the bias goes to the Friday night partner. But the point of discussion here, what I am coming to when I put up this topic of focal ablation, since we are now moving to an era where we are having a voluntary PSA analysis of each and every individual after the age of 50. And subsequently, as per our protocol, we are doing MRI first, followed by the biopsy. So subsequently, we are shifting from a systemic approach to a more targeted approach. And when we are considering the targeted approach, and we are able to find a localized disease in suppose a hemigland or maybe a 1 centimeter lesion in an isolated lobe of the prostate, where rest of the biopsies are negative, then in such kind of patients, I won't mind referring to a specialist or myself for that sake, where I am competent enough to do a focal HIFU and ablate that lesion and keep the patient on follow-up. If I see a more generalized disease where both sides biopsies are positive, target is positive, and it's a whole gland kind of ablation, I will be more happier to send to my radiation friend rather than subjecting those patients to a more whole gland HIFU. Because like Dr. Anandan clearly pointed, we have to weigh the risk. What is the risk? What we are looking for the patient? If it's a hemigland focal ablation, definitely the IR guy or we ourselves as a urologist, if we take up the HIFU program, we are competent enough to treat it. But when we see as a whole gland scenario, I think definitely we have to give it to the radiation oncologist to do a cyber knife or maybe a true beam or halcyon.
Okay. Yes. So that's a good answer. Now, I will bring in some very crucial points. So, for example, you have a patient now who has locally advanced prostate cancer. That means the prostate cancer is not limited to the prostate. It is either just extending a little bit outside the prostate and probably hitting on the seminal vesicles, or probably there is some breach with the loss of fat planes with the rectum and so on and so forth. So we'll have a quick description about how you would all manage this. So I'll bring in Dr. Sudhir. Dr. Sudhir, how would you manage a locally advanced prostate cancer in your practice? Let us assume for the sake of discussion that this is a patient who is going to live for more than 10 years.
With locally advanced cancer, which is not amenable to complete stage 0, after the surgery, I will definitely going for radiotherapy rather than subject the patient to incomplete eradication of the disease. Locally advanced cancer, definitely it is. Hello.
I
Sir,
think there is some
we can't.
network issue.
Yeah.
There is a
It is
network issue
locally
from my
advanced.
end.
I will definitely go in for radiotherapy rather than subjecting the patient to having incomplete treatment with the surgery. Locally, this is radiotherapy along with the, of course, EDT.
So just to highlight it to all my audience and the panelists. So basically, whenever we have a locally advanced prostate cancer, the immediate surgery may not be possible in those patients, irrespective of whether they are really young or old, because the morbidities of surgeries can be a little higher and the results also may not be that good. So there are two strategies that many of us employ. Is one is that we give androgen deprivation therapy. What is androgen deprivation therapy? In this therapy, you are giving medications which will reduce the testosterone levels in the body, and due to which the stimulation of the prostate cancer cells by the body's androgens are reduced to a great degree. Now, this kind of reduces the fuel. This kind of reduces the fuel to the prostate cancer cells, and cancer cells, many of them die or many of them shrink. And once they shrink, it is probably much easier for us to, for these patients to undergo the definitive therapy. Now, just wanted to ask one single question, because this was something which was asked by one of my patients recently. I had a patient who came for androgen deprivation therapy as a neoadjuvant protocol. That means before giving definitive therapy either through radiation or surgery. This patient had an excellent response. In 3 months, the patient's the tumor size reduced so much that if I had not mentioned it to my colleague that I had given neoadjuvant hormone therapy, it would be considered as localized prostate cancer. So the question that I would ask to Dr. Anandan is, Dr. Anandan, would you still like to operate this patient who has undergone an excellent response to neoadjuvant therapy?
So definitely yes, because the disease is always under control if you are giving the anti-androgen. It cannot cure the disease. So if you want to give him a cure, either you have to operate or give radiotherapy. So the patient has to be counseled that your disease has been treated and it is under control now. It is better to do some curative treatment now rather than wait for it to grow further.
So but the reason I asked this question is, this patient was told you may either receive radiation and a very small chance is there for surgery. And you know that patients always would prefer to have a radiation, a non-invasive procedure over a surgery. So what would be your points to tell the patient that, you know what, the surgery would be better for you than just undergoing radiation?
So surgery, the benefit is we are removing the gland or the tumor completely. In this is how I explain to the patient usually. So in surgery, we will be removing the prostate gland or the organ which is affected by the cancer completely, and in radiation we will burn it with some radiation. So if we are removing it completely, there is a high chance that we are removing it completely and there is no residue. If we are burning it, there is a small chance that there might be some residue which can come back later. This is how I usually explain to the patient, and that's why I always I tell them there is a both are almost equal, but the surgery has got a little bit edge over the radiation. So if the patient has very good with the neoadjuvant therapy of anti-androgen, if he has a good resolution of the tumor, if it is amenable for surgery, I would offer him surgery rather than radiation.
Okay, right. That's a good point. So my next question to Dr. Himesh. So you have a patient with locally advanced prostate cancer. The patient undergoes hormonal therapy. Then the patient undergoes radiation therapy also, and the patient does pretty well receiving hormonal therapy even after radiation sometimes. And the patient comes back after 6 or 7 months with a local recurrence. Now, how would you manage a patient like this?
So I would say that whenever like a locally advanced cancer, and we start on a hormonal therapy, and then subsequently we have added a radiation for the local control also. So ideal scenario is to wait for 2 years approximately before we term it as a local recurrence, because there the unless we do a biopsy and all, and unless the patient the PSA has reached nadir, we cannot term it as a local recurrence in just 6 months. What I would say, ideally we have to wait for two to 3 years of hormonal therapy, because the maximum effect of radiation comes in 2 years. So before that, we cannot term this patient as a failure for radiation. So my preference will be, I will first start the hormonal therapy. I'll see for the PSA nadir how much we are able to achieve. As long as it comes below 2, I am happy. I'll be radiating the patient depending on what kind of locally advanced we are talking about, whether it's just a seminal vesicle invasion or maybe one node here and there positive. We will try to cover with radiation this the entire field, and then wait for 2 years before we term those patients, and according to our Phoenix criteria regarding patient having a recurrent disease.
Okay, that is a very important point in practice, because you get anxious patients who probably have undergone radiation. They are even undergoing hormonal therapy in some cases, and then they come with a small lesion in the scan and they say that, oh my God, I got the disease back now, please get it operated. I have had a patient like this in my practice, and exactly what Dr. Himesh said, we did that for the patient, continued on ADT, monitored the prostate specific antigen levels, and kept on a very close follow-up. I think close follow-up is extremely important. Most of these patients may continue to respond, but there will be a few patients who are known to actually blow up. They start growing like anything, and at that time we don't wait for any of the criteria. We just go and offer them either a surgical salvage or any other techniques that would be deemed fit by the urologist. So let me ask Dr. Sudhir this question. This is a very interesting question, and I have had this problem once in my career. I had a patient who underwent surgery, a very good radical prostatectomy done by my esteemed. Sorry,
Hello?
can you hear me? Sorry, I can't hear you well at all. Yeah, so let me ask this question again. So a patient who underwent a very good surgery.
Huh? Okay. Go.
Sorry, I can't hear you. So till Dr. Sudhir gets back his connection, can I ask this question to Dr. Anandan? So if it's a patient who actually has had undergone a very good surgery, and then the patient comes back, but the PSA levels are still around 2 or 3, not exactly undetectable or very low, how would you approach this patient?
So usually after surgery, by 3 months, the PSA should be undetectable in the patients who have undergone a prostatectomy. If there is any persistent rise in the PSA, it shows there is any some disease lurking back in his body, whether it is in the localized area near the prostate, or it is in the metastatic where it has spread beyond to the bone or somewhere else, needs to be found out. So if the PSA doesn't come down to normal level, so if the patient has not undergone any PSA method, I would like to repeat a PET scan to know whether there is any local light up area within the bones or in the prostate bed. And if there is no light up area, either we can start him on hormonal therapy and follow him up, or just follow him up for the PSA to further rise to know exactly where it is recurring, whether it is recurring in the tumor bed or in the metastatic in the bones, and treat accordingly. If it is in the tumor bed, we can give him the option of radiotherapy also, and then take it from there. And it is always important to know the basic stage of the disease in the biopsy specimen. If there is any obvious positive margins, large positive margins, or invasion of seminal vesicles, we are giving them the option of radiotherapy after surgery to prevent such scenarios.
Okay, so that's very well answered. Let me summarize it for the audience. Number one, if you undergone a surgery, don't expect that the day 3 of the surgery, the PSA will be 0. It can take up to 3 months. So please don't panic if your PSA is still detected after 3 months. And after 3 months, if the PSA is detected again, it is not just about detected alone. You can repeat it maybe 2 or 3 times. There are going to be these odd patients who may take that extra few days to actually have undetectable levels. And if there is a rising PSA in the next few tests that we are doing, that is definitely alarming. And during this time, you have to consult the urologist, oncologist back, because we will have to do further analysis to find out if there is any remnant prostate cancer tissue in the operated area, or whether the prostate cancer tissue has spread to some of the nearby areas or to the other organs like such as bones. So after that, if it is showing that it is only in the prostate bed area, then radiotherapy will be offered after discussion with the patient. And if it has spread to other organs, if it is spread to other organs, then we will probably get to refer to a medical oncologist, where we will plan for, depending on the patient profile, either androgen deprivation therapy further on, or we will go for a combination of androgen deprivation therapy with chemotherapy. So these are many options that are available to us. I will ask the last question of the evening to Dr. Sudhir Chadha. I think he was unable to answer his question, so I had to move over to Dr. Anandan. So whenever you get a patient who comes to you with the prostate cancer, and you know that the patient's father or a first degree relative had a cancer, and you are suspecting that this prostate cancer is due to familial predilection, how do you approach this patient, Dr. Sudhir? I think you're on mute.
Is it okay now? I'm audible?
Yes. Please go ahead.
If a patient comes to me with the high suspicion of prostate cancer diagnosed as a familial prostate cancer, again, most of these patients are well motivated, and they have got, they somehow know the, nature of the disease. These patients are very much amenable if they are in earlier stage and relatively good disease, greater disease. They are very much amenable to aggressive treatment. I will definitely more aggressive in these patients.
Okay. So, does your approach for treatment change, whether it is localized or locally advanced in these patients, or it remains?
It all, treatment is same protocols are followed, but these patients are well motivated, and they are amenable to whatever aggressive treatment we are able to tell them.
Okay, that's great. So it is important for the audience to know that there is something called as a hereditary prostate cancer. You may be having a parent who has a prostate cancer or any other cancer which is related to a very commonly understood gene called as the BRCA1 or the BRCA2 gene. And whenever you have a prostate cancer in a patient who has a family member a close family member who has had any cancer related to the BRCA gene, it is always important that once you get the biopsy done, you should do a genetic testing for this patient to know whether this patient has prostate cancer due to the commonly known gene called as BRCA1 gene. So it's very important to not neglect this, because if you have been diagnosed to have cancer, you may get cured of it. But if you are carrying the gene, it may help your progenies, your children, to prevent or have a prevention strategy so that they don't get any BRCA1 or BRCA2 related cancer in their lifetime. So it's a very important point that we have to understand, that there is a lot of intricacies in the management of prostate cancer, and very importantly, it's a very shared decision. The patient is important, but also the urologist is important, because please remember that it is important for us to cure prostate cancer in the first attempt. If you are unsuccessful in the first attempt, then it is a catch-up game. Very seldom do we see patients getting a second chance at getting cured. So very important that every step is purely monitored in a very standard way. And as Dr. Himesh said, there are a lot of changes that are happening in the scene of prostate cancer. Like I said, his protocols have already changed with the latest of the recommendations, and I'm sure that as time goes on, we'll get newer recommendations in the management of prostate cancer. So with this, I end my questions. I would like to give some closing comments from each of my panelists, so that we can close it with a summary given by each of my panelists. So let me start with Dr. Anandan. Kindly give me a summary about how you would like to manage prostate cancers in 2025 and beyond.
See, the management starts with the diagnosis first. So my advice would be to get a PSA test done after 50 years of age. And as said maybe panelists, if you have any family history, start a little bit early by 45 years also. Get a PSA test done. If it is high, and consult a urologist, get the further investigation like MRI and biopsy done, and get it treated. Depending upon your stage, and depending upon your other health conditions, whether you discuss with your urologist and your oncology colleagues whether you want to undergo surgery, radiotherapy, or any other newer advances. The main thing is do a PSA and get the cancer detected, if at all you have it, at the early stages for a good cure.
Great. Dr. Himesh, would you like to add to the points added by Dr. Anandan, any of your personal favorite comments that you want to make in the next 30 seconds?
I think in all the discussion, we just we just were not able to discuss about the genetic screening also. And now in India, we have some of the tests available where we can do some kind of genetic analysis of the cancer, like Prolaris test and Decipher. So this also should form as a part of our protocol, where in the pre-treatment zone, as well as once definitive treatment has been done, where we can prognosticate whether these patients are eligible for any adjuvant or a salvage treatment, and we can give a more better understanding of the nature of the disease to the patient.
Fantastic. So, like I said, for the lack of time, we could not discuss the genetic screening part. It is a very important part, and we have to understand that a lot of prostate cancers have a genetic basis. And nowadays, especially in my field, when the patients come to us after failure, post surgery, or radiation, and we call them as advanced prostate cancers, we are using a lot of genetic based therapies in your practice. We are using immunotherapies, we are using radionuclide therapies in certain cases. So it is definitely important for us to know the genetic basis of cancers, because that is like a lock and key therapy. We will be able to give the personalized therapy to the patients and just avoid chemotherapy in all patients. So it's very important. Well said, Dr. Himesh. And may I get some closing comments from Dr. Sudhir before we wind this up?
Our closing comments will be that we should be always be aggressive in diagnosing the disease, and of course, first attempt is the best attempt to eradicate the disease. And we tell the patients, if God forbid if cancer is there, we are always there to help them out.
Correct. So, very eminently, panelists have told about management of prostate cancer in their practice, how they manage prostate cancer patients. As I said, as a medical oncologist, I get to see prostate cancer patients when they are advanced or when they have failure to therapy. And sometimes I do get the patients referred to me for neoadjuvant hormonal therapy or adjuvant hormonal therapy after radiation or before radiation. So it's very important that we all work together. Please remember, patients, that whenever you have a cancer, it is always good to do a multidisciplinary management. It is important that your case is discussed by the urologist, the radiologist, the medical oncologist, and the radiation oncologist. Whenever you have multidisciplinary management of any cancer, they have found that the results are excellent, the cost is saved, and also the outcomes are going to be a lot more durable, if not curable. So it's very important for us to always remember that there is also a genetic basis for cancers that has also got to be discussed. Let us not think of cancer like in the 90s or 2000s, where we used to just treat the cancer and forget about the cause. Nowadays, we are extremely concerned about the cause of the cancer, and also we are now looking at era where we are looking at reducing the side effects of the treatment for the patients. We want to make sure that the patient has got a very good sexual function after surgery. We are very keen on getting a very good urinary function for the patient after the surgery. Now we are very keen on getting less radiation toxicity to our patients. And in my field, we are looking at giving the least morbidity due to hormonal therapy, such as cardiovascular morbidities. We want to reduce it as much as possible for our patients, because most of these patients are going to come to us in that stage or age in their life where they have diabetes, hypertension, heart problems, and all that. So, with this, I thank you to my esteemed colleagues, and I thank Voice of Healthcare and Mankind and Bharat Serums Vaccines for this wonderful forum that they have organized. It is indeed a national prostate cancer forum, because we have from north to south eminent urologists, and I am also from the south, and Dr. Himesh is from central India. So we are very happy to give you all the information that I've given you in the past 1 hour. And if you do have questions, please write to them, and we'll be able to answer it in our free time. Thank you again, and back to the hosts.